Hi there, I'm Haley Colavo. I'm the Director of Brand Awareness here at Southend Pharmacy. I'll be helping host the webinar today and really excited for the presentation we have planned for you all. A quick disclaimer before we get started. We basically just wanted to say that this presentation is for educational purposes. It is not intended for anything further than that, and we are actually have compounded medications that are not FDA approved, so just take this presentation as intended. Thank you so much for your attention to that. Today, I also wanted to introduce from our Southend Pharmacy team, our clinical support, Asiya Askari. She is our clinical pharmacy supervisor here at Southend Pharmacy, and she ensures to work towards the highest standards in compliance and efficiency here with operations at Southend Pharmacy. She's so passionate about mentoring her team, workflows, researching new formulations, and we are so happy to have her today as our clinical support. Just wanted to introduce her.
Thank you so much, Haley. Thank you for having me here today. I am extremely excited to be part of this new launch at Southend Pharmacy. As we go through this presentation, I will be more than happy to answer any questions that may arise regarding our new products.
Absolutely. And just a few housekeeping items. So we will have an interactive QR code during the presentation. This will allow you to submit your questions and give you the ability to input those, and then we will have the presenters and Asiya answer any of those questions live at the end of the presentation. And today's presentation will be recorded, and a follow-up on interest in some of these topics, including a link and a recording, will be sent out to all of our registrants. Thank you, Asiya. A 503A based Houston-based compound pharmacy committed to delivering sterile medications for your patients. And we are operating and shipping in over 40 states across the United States now. This allows us to provide medications to patients who really need them and have appropriate access to the solutions they need. Now we can kind of dive into a little bit more about our commitment to excellence and just what it means to be a part of Southend Pharmacy. So first, I just wanted to highlight that our facility is not just a place we work. It's really embodied our dedication to every medication we produce. And this means that each compound is crafted with the utmost care for your patients. So we are legit script certified, which also gives a seal of compliance and integrity in our pharmacy industry. This certification assures patients and providers that we follow guidelines and regulatory adherence. I also want to touch on our third-party testing. This creates transparency. It builds trust and confidence with our outcomes for providers and patients. And then through these practices, we ensure our compounds are met to the highest expectations and the needs of the patients we serve. So now the moment I'm sure everyone's been waiting for. Just wanted to briefly introduce our new products. NAD. This is a medication everyone has been very excited about and requesting, and we're very excited to be able to bring these to your practice, in addition to Sermorelin. And we will go into detail about the clinical applications of these medications next. First, I would love to introduce our presenter. Dr. Willie Villarreal is a doctor of nurse practitioner. He specializes in integrative medicine with over 10 years in private practice. He began his career by founding a sports performance and recovery clinic where he worked with professional athletes to optimize their performance, recovery, and prevent injury. He is also the founder of Core Health and Wellness. And today he continues to provide care plans to patients that blend advanced medical therapies with integrative support and attending to all walks of life of patients to achieve their peak performance and longevity. He's great at translating complex medical concepts into practical insights. And when he's not at practice, he advocates for healthy living, preventative health, and a mindset for achieving long-term wellness, and spends time with family. Next, I will just invite you all while we get him queued up to participate in a poll so we can get an audience check on how everyone actually is using these medications. Are they using them in their practice currently? If you'll use the QR code, we would love to hear from you. And this will kind of help our presenter shape his discussion surrounding NAD and Sermorelin. So we'll give you a few moments to submit those, and then we'll be back with Dr. Willie. Thank you so much. Very exciting. It looks like we have quite a few of you utilizing these medications already in your practice. It looks like a lot more NAD than Sermorelin, but looks like there is a great familiarity level. So really excited to dive into the clinical aspects of using these and just some of the best practices that I'm sure all of you have joined today to hear. So without further ado, we will send the presentation over to Dr. V.
Hi, everybody. Thanks. Hey, how are you?
Thanks for joining.
Southend for having me. Today. I kind of told them earlier. I don't know if y'all can see me, but it'd be great if y'all didn't have to be subjected to my face. But I told her earlier that I actually have anxiety about this tech. I would rather be in front of like thousands of people on stage than on right now with all this tech. So it's if I fumble my words, apologize. But first off, I'd like to start by asking questions like what if I told you that two molecules, one discovered over a century ago, because these aren't new, and the other derived from a 29 amino acid fragment, might hold the key to aging, not just gracefully, but biologically younger. So by the time that you're 50, your NAD plus levels may be half of what you were at 20. Your natural growth hormone is barely flickering. But what if you could restore both and actually feel the difference? In today's society, a lot of y'all's patients, just like mine, they want to They want to feel something. If they don't feel something, a lot of times they don't feel like anything's working. We don't have to accept the fatigue, the brain fog, the slow recovery, basically the typical course of aging in our society, as simply just a part of getting older, okay? Especially when science now shows that we can reverse some of it. Too many times I hear patients coming in saying, you know, I've gone to my PCP, I've gone to some of my docs, and I've gone to 3 different doctors, and they've all told me, well, your labs are normal, you look great. And they come back and just basically say, I don't feel great. I don't know what the labs, I don't care what the labs show. I just don't feel well. And that, I'm sure for a lot of y'all is kind of the same story. My overall goal today is basically try to explain a very, complex concept very simply. Okay. NAD and Sermorelin have been really, really, really great modalities in my clinic. And my goal today is just to help you kind of understand the roles of NAD and Sermorelin, discuss the mechanisms of action in clinical applications, review some of the studies and literature, because it is pretty, there are a lot of peer-reviewed studies and literature on both NAD and Sermorelin. And then basically at the very end, learn practical integration strategies that you can implement in your clinical practice. So NAD simply is just a vitamin D3 derivative of niacin. That's basically what it is. It's a naturally occurring vitamin in the body, but it's essential. NAD is essential. I can't stress that enough. It's an essential compound necessary for a whole host of metabolic processes in the body. NAD actually has a very, very, very long history. And in the early 20th century, it was basically discovered and used mainly for as an alcohol fermentation enhancer. And in all honesty, if NAD hadn't shown the potential to improve booze, it probably would have gotten totally forgotten about. So fast forward to 1938, nicotinic acid or niacin was actually discovered as a precursor to NAD. NAD was then immediately used to cure what's called black tongue disease in dogs, which is basically the dog version of pellagra. Pellagra does a cure also in humans. It is basically a nutritional disorder of deficiency of vitamin B3 or niacin. And sometimes it's a precursor tryptophan. It is characterized by the 4 Ds, which is dermatitis, diarrhea, dementia, and if not treated, death. Pellagra was most common in populations with poor nutrition, or a lot of those relying heavily on corn-based diets without proper processing, because untreated corn actually lacks bioavailable niacin. Treatment simply involved niacin supplementation and dietary improvements. The connection, though, of NAD to cure pellagra highlighted the importance of NAD in human health and led to nutritional interventions that effectively eradicated pellagra in all the affected regions. By the 1960s, though, a lot of the researchers basically concluded that all of the interesting research on NAD had already been done. So for about the next few decades, NAD was kind of primarily viewed as a housekeeping molecule, basically a simple coenzyme that was involved with basic metabolic redox reactions, like glycolysis, the citric acid cycle, and the biggest word, if everybody remembers, oxidative phosphorylation. Everything though changed, and this is where a lot of y'all may pick up on where it comes from. But everything kind of changed in the 90s when 2 doctors, Dr. Lenny Guarini and Shinshiro Imai from MIT, they showed that NAD wasn't just keeping things running in the body, it was a central regulator of many biologic processes like aging and disease. They primarily showed that NAD acts as fuel for sirtuins. Without sufficient NAD, sirtuins don't work efficiently. So we'll discuss sirtuins briefly in just a sec, because it's important to know exactly what they are and how sirtuins affect aging. So going back to the studies, there are a lot of studies, but more so a lot of recent studies. 2024 systematic review that was titled Evaluation of Safety and Effectiveness of NAD in Different Clinical Conditions. It analyzed 10 randomized clinical trials that involved over 489 patients across various health conditions, which included chronic fatigue syndrome, Parkinson's, Alzheimer's, postmenopausal, and prediabetes, as well as overweight individuals. The key findings were basically the supplementation with NADH and its precursors. NADH is basically NAD with a hydrogen molecule. It's a lot of the precursors was generally well tolerated. Just common side effects were mild and muscle pain, nerve disorder, fatigue, sleep disturbances, but no serious events were documented. Basically, the study efficacy indicators were that participants experienced improvements in several health parameters, which included reduction in anxiety levels, maximum heart rate following stress tests. They enhanced muscle insulin sensitivity and insulin signaling. There's a very interesting study that we'll discuss in just a second on that. Improved quality of life, decreased fatigue intensity, better sleep quality. And this was particularly noted in the chronic fatigue patients, chronic fatigue symptom patients. The overall conclusion was that oral NADH supplementation appeared to be safe and may offer benefits enhancing general quality of life and certain health parameters. However, the authors emphasize the need for further research to determine optimal dosing, and that's kind of where we all come in, and to substantiate the clinical benefits of certain specific diseases. NAD for certain specific diseases is still an evolving field. So overall, the mechanism of action for NAD is it just plays a crucial role in a ton of various cellular processes. Number one, redox reaction. So NAD, it functions as an electron carrier in the metabolic pathways, including glycolysis, like we discussed earlier, the TCA cycle, and oxidative phosphorylation. It alternates between oxidized NAD and reduced NADH states, facilitating the transfer of electrons and supporting ATP production. And two, it's very important for DNA repair. Excuse me. Adequate NAD levels are essential for maintaining genomic stability. All right, so sirtuins. Sirtuins, they're basically a group of 7 regulatory genes. There's SIRT1, SIRT2, all the way to SIRT6, et cetera. They have 2 different and competing functions in your cells. Number one, they govern the epigenome, which is basically your epigenetics, something that we go through now. So my background, I did a year-long fellowship in DNA and genomics, big believer in DNA. But now what I explain to patients a lot of times when they come and they say, well, my genes, I'm just bound to have it. My dad had it, my mom had it. What we know now about genes is it's about 80-20. It's about 80% epigenetic, 20% genetic. In other words, y'all have probably heard the saying that DNA or genetics loads a bullet in the gun, but lifestyle fires that gun. So the sirtuins basically, they govern the epigenome and they turn on the right genes on at the right time in the right cell. And this will boost mitochondrial activity, which reduces inflammation, and then it protects the telomeres. The telomeres, the best description I ever heard on telomeres was it's basically the little covers on the end of the DNA strands, like aglets, the little plastic covers on the end of shoelaces. And telomere length is directly correlated with life extension and expectancy. Number 2, they direct DNA repair. So as we age, sirtuin activity generally declines, and this has an important consequence for cellular health, metabolism, longevity. Well, fast forward to today, who do you suppose just happened to be a postdoc researcher on Dr. Larry Guarini's team at MIT? Basically, it was none other than the world's current foremost expert on NAD, which is Dr. David Sinclair. So Dr. David Sinclair was working with Dr. Guarini, and he co-discovered the SIRT2 gene, which promotes longevity by a mechanism that depends on NAD. If y'all haven't read it already, I highly recommend Dr. David Sinclair's book. It's called Lifespan, Why We Age and Why We Don't Have to. His book really highlights, it goes really, really deep into NAD, but it highlights aging and Dr. Sinclair's 3 major anti-aging research focuses, which is NAD, resveratrol, and metformin. Resveratrol, it's very important to understand. I know it's also really hot and things, but if you understand resveratrol in his studies, the recommendation for resveratrol is about a gram a day, 1,000 milligrams. A lot of the supplements that you'll see that they're touting on the internet, and as far as resveratrol, have like 50 milligrams of trans resveratrol, which isn't very, very much. But basically, in summary, you can simplify it to this: aging, as we age, lowers NAD, which then lowers sirtuin function, which increases DNA damage, which increases inflammation and decreases mitochondrial efficiency. So the overview of NAD, basically, going back, is, why are these therapies gaining popularity? Because everybody is interested in anti-aging. Okay, everybody is interested in feeling better, not just extending your lifespan, but extending your health span. I tell patients all the time, it's like, we can already extend your lifespan, but like I described earlier, the typical course of aging in our culture is kind of, we expect to have forgetfulness and brain fog and joint pain and just not feel well, and the prospect of that leaves a lot of people, they don't want to live to 70, 80, 90. What NAD can do is be a really, really important tool to extend the health span, which is how many lifespan is basically how many years you live. Health span is going to be how many years you live healthy, how many years you perform well, you feel well. NAD is a really, really, really important tool in the toolbox for that. So another study, again, 2024, it was titled "A Therapeutic Perspective in NAD Precursors in Age-Related Diseases," provided a comprehensive analysis of potential benefits and limitations of NAD. Basically, precursor supplementation, which you hear are the two main ones that are out there, are NR, which is nicotinamide riboside, and NMN, okay? That's nicotinamide mononucleotide. That's what they use in this study, but this one was very important in basically showing the role of the microbiota, okay? This study, it highlighted the significant role of gut microbiota in NAD metabolism. The orally administered NAD precursor interacts with the gut microbiome, and suggesting that the individual microbiota compositions may influence the efficacy of supplementation. So different people's gut bugs are going to dictate how well they absorb or don't absorb it. Again, this is one of the reasons I do like the injectable NAD versus the precursors, because while the precursors do work well, and we can talk about bioavailability later and things like that, the bioavailability of course IV is 100, but the bioavailability of injectable is near 100. Okay, so the NAD precursor supplementation had holder promise for counteracting age-related NAD decline and associated diseases, but the translation of the preclinical benefits to clinical outcomes was limited. The interplay with NAD metabolism and gut microbiota present a compelling avenue for future research, aiming to enhance the therapeutic efficacy of NAD precursors in aging and age-related diseases. Again, I think we could bypass a lot of that, because again, this was from NAD precursors, the orals, and we can bypass all that with the injectables. This is one of the main reasons that sub-Q delivers NAD more efficiently. So NAD clinical evidence, some of the key conclusions of this study on muscle development, homeostasis, and aging was the central role of NAD. So NAD was pivotal, and was shown to be pivotal, in skeletal muscle for energy metabolism, mitochondrial function, and cellular signaling. The impact of NAD showed that maintaining adequate NAD levels is crucial to muscle development, regeneration, and homeostasis. Declines in NAD were directly associated with muscle degeneration, impaired regeneration, and age-related muscle loss or sarcopenia. That is one of the main things that I stress to patients, is I want them to maintain muscle mass. Muscle is our most important metabolic currency. It is extremely important to maintain our vitality and our health as we get older. And not enough people are actually paying attention to maintaining muscle mass and preventing sarcopenia. In the study, the therapeutic potential was interventions that boost NAD levels, including supplementation with NR or NMN, as well as lifestyle modifications like exercise, may enhance muscle health and counteract age-related decline. In summary, the sustaining the NAD levels and homeostasis is vital for skeletal muscles function throughout life, and strategies to maintain or restore NAD levels hold promise for improving muscle health and mitigating age-related deterioration. We need to start treating aging as a disease, not just something that happens to us, something that we can affect. So more clinical evidence. This basically showed the model of pathological observation in the age muscle and their reversal by augmenting nuclear and mitochondrial NAD levels. Fewer mitochondria equals fewer stem cells, leading to reduced levels of NAD in the nuclei and mitochondria, and it reduced SIRT1 activity. These were observed in aged muscle. Repleting NAD levels in nuclei and mitochondria via various interventions that increase the mitochondria, increase muscle stem cells, increase nuclear mitochondrial NAD levels, and thereby it increased SIRT1 activity. One mechanism involves nuclear SIRT1 mediated regulation of, it's basically TFAM and PGC1 alpha gene expression in this study, and their effect on mitochondrial metabolism. This one is really cool, and it showed that intestinal NAD biology plays a really important role in intestinal homeostasis, and the administration of NMN, which is, as we discussed, is one of the NAD precursors, increase intestinal NAD biosynthesis and positively influence gut physiology. Furthermore, NAD precursors have been described as potent anti-inflammatory agents. Now, again, more of the studies have been done on NR, which is nicotinamide riboside. There are some clinical studies on NMN, but they're not as robust or as many as NR. Again, these are the orals, a lot of variables that go into how well they're absorbed, and the bioavailability is less. It does raise levels, but not to the extent that sub-Q does. So this one is really interesting as far as like cardiovascular health. So NAD participates in several key factors in cardiovascular disease. That's cardiovascular health is actually one of my kind of wheelhouse, my background. I was on an open heart team. I have a surgical company that I've also owned for over 20 years. And my first love is actually cardiovascular surgery. I was a RN first assistant for many years. And I was the one that was doing the endoscopic vein harvesting, preparing the vein for bypass, and then I assisted up top. So I have a deep, deep love for cardiovascular health and how to affect it. NAD protects against metabolic syndrome, heart failure, ischemia reperfusion injury, arrhythmia, and hypertension. Subsequent loss of NAD in aging or during stress results in altered metabolic status and potentially increased disease susceptibility. So real quick, before we jump into best practices, I want to address one of the most common questions before it gets asked. I get this question asked all the time, thanks to our wonderful internet and social media experts all over, all over social media. And it regards the risk of NAD in cancer. You may have heard some people say, no, that you shouldn't be using it and it can cause cancer. For this, again, I defer to the expert, Dr. David Sinclair, who studies it day in and day out. Okay. Dr. Sinclair's perspective on NAD and cancer risk basically states it. He acknowledges that some studies raise question about the relationship between NAD levels and cancer growth. For instance, a study from University of Washington found that reducing NAD levels in the brain, in brain tumor cells, actually slowed their growth. Okay. However, Sinclair emphasizes that this finding does not imply that increasing NAD levels promotes cancer. They made an incorrect extrapolation, or should I say, a lot of people are making the incorrect extrapolation and saying, well, if it makes it, improves the tumor, then it must, cause the tumor or at least make it worse. Basically, Sinclair had a great analogy, and he likens it to saying that removing wheels from a car stops it from moving, but adding more wheels to a car doesn't necessarily make it go faster. Okay, that's a great analogy. And so basically showing that raising NAD, it's not going to contribute to development or progression of cancer. Now, another 2019 study observed that mice genetically they were genetically predisposed to developing pancreatic cancer tumors. They develop more precancerous and cancerous tumors when given NMN, which is a precursor to NAD. Dr. Sinclair notes that the effect was seen in mice already prone to cancer. They were already specifically engineered to develop cancers more readily, and was more related to the downregulation that they have of a tumor suppressor gene called P53. So it's basically the current understanding and recommendations points to the studies where the NMN were administered to the normal mice without a predisposition to cancer. The mice live longer and healthier lives. He has a ton of studies, and there's some really cool, like, anecdotal evidence he talks about in the lab of giving the mice specific NAD boosters, and the mice actually breaking the exercise wheel that they use to test their longevity. Actually, the NAD boosters actually made the mice live longer and grow stronger and go further as far as their exercise intensity, pushed out lactic threshold. So Sinclair basically, as a summary, he emphasized that while the data so far does not show a direct link between NAD boosters and increased risk, in healthy individuals, research is ongoing, and we'll talk about caution later. But patients, especially those with pre-existing or existing cancers or predisposition cancer, should consult with their provider before starting NAD supplementation. But overall, there is no conclusive evidence that NAD boosters increase cancer risk in a healthy individual. Proper screening should basically include an evaluation for their symptoms: brain fog, fatigue, poor sleep, slow recovery, which is pretty much makes up every single one of my patients that comes in. Screen them for neurologic or cognitive issues, memory decline, MCI or mild cognitive impairment, substance abuse history. NAD is very popular and growing in popularity with addiction recovery programs. It really helps them with the withdrawal symptoms. Metabolic conditions like type 2 diabetes, metabolic syndrome, mitochondrial disorders, autoimmune, use it a lot with my autoimmune patients, chronic and inflammatory diseases. Some of the red flags and precautions are got to be careful with a history of active cancer due to the theoretical concerns about enhanced cellular metabolism. Make sure they don't have hypotension, and we'll talk about that why in just a second. But low blood pressure. NAD can transiently lower blood pressure, liver or kidney dysfunction, and make sure they're not pregnant or breastfeeding, which it's just not well studied. Physical exam is your basic physical exams, your basic vital signs, blood pressure, heart rate, overall general assessment of their energy, skin tone, hydration status, neurofunction. Lab testing, this is one question I get a lot, okay? Basic lab testing you want to be getting is just CMP, a complete metabolic panel, CBC, fasting glucose and insulin levels, lipid panel, inflammatory marker like a HSCRP or high sensitivity CRP. Here's a controversial question I get all the time is, should we check NAD levels? Okay, well, here's the thing about NAD labs. You can get direct whole blood testing for NAD and NADH levels, but these are very expensive for the average person. They're $200 to $400, plus the direct blood testing is actually of NAD is actually very unstable, and like sample handling is really critical, so that can affect the results. There are metabolomic panels. Genova Diagnostics has one. It actually checks for the precursors of NAD metabolism, but they're also very expensive. They run about $399 to $500. Patient goals and indications that identify therapeutic goals should be improved mitochondrial function, enhanced cognitive performance, support for detox or addiction recovery, relief from chronic fatigue, anti-aging or longevity strategies. We can talk about those. Contraindications to rule out active or recent cancers, uncontrolled hypotension, severe organ failure, and any known allergies to any like niacin or any NAD preps. Monitoring and follow-up, just monitor for nausea, flushing, some of the things that can happen with NAD. Again, they're very rare, but understanding like nausea, flushing is the same thing. It is very uncommon to get flushing with NAD, but they can get a flush, what they call, it's like a flushing type symptom, which will be more of a chest tightness. It's rare. Happens actually more with IV, depending on how fast you run it, but it can be a dose dependent response with the sub-Q. They can, I've rarely, if ever, seen the drop in the blood pressure, but you can recheck labs every 3 to 6 months if you're using it, long term. Assess energy, sleep, mood, cognitive function. The dosing, this is going to vary, okay? And we can talk in depth, and I can answer questions. Dosing ranges anywhere from 10 to 20. I start at 10 to 20 milligrams daily. And then I titrate up as needed for symptom relief. The prep that Southend has, basically at 5 IUs, 5 units is about 10 milligrams. For the approximate 28-day supply that they have, it's about 7 to 8 units, around approximately 7 to 8 units a day, or about 14 to 16 milligrams daily. You'll see online the therapeutic is anywhere from 50 to 100 or higher milligrams daily. I haven't seen patients need that much. I personally use about 20 to 30 milligrams a day. I like to do it Monday through Friday. But the possible, main possible side effects that you're going to have to, worry about, and you've probably already seen, is just flushing and warmth. They can get a little bit of chest pressure, lightheadedness, but they're not really it's not really a true niacin related flush, like the full red face and things like that. So this is just a simple, y'all probably can't see it on the notes, but this was a testimonial that I had one patient have. And basically, his name was John. He says, at 60, he says, I was feeling like my best years were behind me, constant fatigue, brain fog that made it hard to concentrate, and joint pain that made everyday tasks uncomfortable. After starting NAD injection therapy under medical supervision with Dr. V, I experienced a remarkable turnaround. Within just a few days, my energy levels improved, my mind felt sharper, my stiffness in my joints significantly eased. It's like someone turned the lights back on. I'm more active, focused, and engaged than I've ever been in years. NAD therapy has been a game changer for my quality of life. That is kind of the common response that we're seeing pretty much across the board with the patients that are using it. So as we shift our focus a little bit to Sermorelin, I want you all to first understand what it is. Sermorelin is basically a synthetic growth hormone releasing hormones, or GHRH, specifically GHRH 1-29. Its primary role is to stimulate production of growth hormone in the body. It was first developed in the 70s and 80s during research into growth hormone deficiencies and pituitary function. Scientists started isolating and synthesizing biologically active fragments of GHRH. Sermorelin received its FDA approval under the brand name Garif by Serona Labs in the 1990s. It was approved. It's still FDA approved, but it's approved specifically for diagnosing and treating growth hormone deficiency in children. Okay. Production of Garif was discontinued in 2002, but Sermorelin remains available through a lot of the compounding pharmacies in the U.S. and including Southend. Now, why is this important? Why do we need, or you need to even explore using a GHRH? Well, Sermorelin basically has what we call natural mimicry. It mimics the natural GHRH that our body produces. This means it can effectively stimulate our pituitary gland to release endogenous growth hormone. Age-related hormonal decline. A lot of the research indicates that Sermorelin may counteract declines in growth hormone levels associated with aging. This could be crucial in preserving our neuroendocrine axis, which often deteriorates as we get older. The potential benefits are basically addressing these declines. Sermorelin could potentially slow the cascade of hormonal failures that we experience with age. These insights basically set the stage for our next discussion on how Sermorelin supports growth hormone and recovery in more detail. So as we delve into the mechanism of action for Sermorelin, let's first understand the role in supporting growth hormone release and recovery. Sermorelin, like I said on the last slide, it mimics natural growth hormone releasing hormone in our bodies. This is crucial because it directly stimulates pituitary gland to release our body's own growth hormone, which then avoids the risk of overdose or suppression of our natural growth hormone, as you see with synthetic growth hormone. It is more physiologic and less likely to cause acromegaly or insulin resistance. Okay, the growth hormone is infamous for causing insulin resistance and blood sugar dysregulation. Now, why is this important? Well, like I discussed earlier, sarcopenia, age-related sarcopenia, muscle growth. By promoting growth hormone production, Sermorelin supports muscle growth, recovery. It can be better. It can provide better recovery, particularly after physical exertion. Overall vitality. It contributes to our overall vitality, which is something that we all strive for as we age. So as we consider the practical application of Sermorelin, keep in mind these key mechanisms that not only help with muscle recovery, also play a significant role in enhancing our quality of life. So as we transition to the discussing age-related hormonal decline, let's take a moment to consider the implications in this context. Research indicates that Sermorelin may play a crucial role in counteracting age-associated declines in growth hormone levels. I'll discuss kind of the normal levels in decline in just a second, but there's been extensive clinical research which supports safety and efficacy in both populations, children and adults, especially for increasing growth hormone and IGF-1 levels without the risk of direct growth hormone therapy. One significant finding from a study published in Clinical Interventions in Aging suggests that Sermorelin can help preserve the neuroendocrine axis. This means it has the potential to slow down the cascade of the hormonal failures like I discussed on the last slide. It's an exciting development because it opens up discussions about how we can better manage age-related adult onset growth hormone insufficiencies. Clinical trials have demonstrated that Sermorelin therapy can lead to improvements in body composition, including increases lean muscle mass and reduced adiposity. These effects are directly attributed to the enhanced endogenous growth hormone and the increased IGF-1 levels. Cognitive function and sleep quality. Studies have also explored the impact of Sermorelin on cognitive function and sleep architecture. The enhanced growth hormone secretion has been linked to improved sleep patterns and cognitive performance. That's another one that immediately they will report is that their sleep is amazing, especially if they've had the typical wakefulness, the waking up at 2 to 3 o'clock in the morning and can't go back to sleep. It's very effective at improving that in patients. So let's talk about the endocrine and metabolic effects of long-term administration of growth hormone releasing hormone in age-advanced men and women. This study was really, really cool, and it showed a significant increase in insulin sensitivity, specifically though among males who are receiving this treatment. The key findings were basically they showed increased growth hormone and IGF-1 levels. The GHRH analog stimulated nocturnal growth hormone secretion, and it elevated serum IGF-1 levels within about 2 weeks of treatment. It also enhanced insulin sensitivity in men. Despite no significant change in their fasting insulin or glucose levels, a notable improvement in insulin sensitivity was observed in male participants. The enhancement was measured frequently by sampling IV glucose tolerance tests. There were major gender differences, like I discussed. The improvement in the insulin sensitivity was significant in men, but not in women, which indicates a gender-specific response to the treatment. Proposed mechanisms were the study proposed that the increase in insulin sensitivity in the men was attributed to the elevated IGF-1 levels. IGF-1 has insulin-like effects on glucose metabolism, which could enhance the insulin sensitivity. It increased lean body mass in the men. An increase in lean body mass was observed in men, which is associated with improved glucose uptake and insulin sensitivity. The findings basically indicate that stimulating endogenous growth hormone secretion through GHRH analogs like Sermorelin may positively influence insulin sensitivity in aging men. Again, this finding is crucial as it highlights the potential of Sermorelin not just for growth hormone issues, but also improving metabolic health as we age. Moreover, the implications of better insulin sensitivity could lead to enhanced overall well-being, impact various aspects of life, from energy levels to weight management. So as we move forward, we'll explore some of the some other related research findings that further support these conclusions. This will provide a clear picture of how we can integrate these insights into our practices effectively. So on best practices, ideally, Sermorelin should be given at bedtime because that's natural pulsatile, the natural time that we pulse growth hormone. Lab draws basically during the day for growth hormone are just don't do it. I mean, they yield either a 0 or low levels. The highest GH level is going to be around 2 to 4 a.m. So unless you plan on having your lab open at 2 or 4 a.m., it's not advisable to draw the GH. IGF-1 does not fluctuate as much, which makes it an ideal screening lab test for growth hormone deficiency or excess. IGF-1 is a great proxy marker for GH. Proper patient screening should be for the use of the Sermorelin is essential to ensure its safety, appropriateness of treatment. The key elements for the screening process are, again, medical history review. Do they have any age-related growth hormone decline? The ideal candidates are typically going to be age 30 plus with signs of low growth hormone, which are fatigue, poor recovery, low muscle mass, cognitive issues, weight gain. Some of these may suggest growth hormone deficiency, but again, they're multivariable. There's a lot of things that cause that. Assess a family or personal history of cancer up front, especially hormone-sensitive cancers like breast, prostate, or colorectal. Make sure that check for history of disease of diabetes or insulin resistance and sleep disorders. Physical exam, just evaluate body composition, excess fat, reduce muscle tone. I use a DEXA. I have a DEXA scan. I love it. I track body composition, visceral adipose tissue scores, things like that before I start. Monitor blood pressure, cardiovascular status. The lab testing, like I described earlier, you should get probably a baseline IGF-1 level, get a fasting glucose and insulin to rule out any and rule out or monitor any kind of insulin resistance. Hemoglobin A1C, just to check for long-term glucose regulation. Thyroid panel. Hypothyroidism can mimic growth hormone deficiency symptoms as well, so make sure that they're not hypothyroid or having any low thyroid hormone issues like low free T3. Liver kidney function test, PSA for men over 40, and again, cancer screening appropriate for their age or gender, such as like colonoscopy, mammogram. Contraindications for using Sermorelin would be to rule out any kind of active malignancy. Make sure they don't have any uncontrolled diabetes. I would get that under control before starting that, as it's it'd be primary. Severe obstructive sleep apnea. Make sure they don't have that because you don't want to affect their sleep architecture before they have adequate care or CPAP if needed. Again, pregnancy or breastfeeding shouldn't be used. Not enough studies. Severe liver or kidney disease. So monitoring after Sermorelin. Make sure you get follow-up IGF-1 levels and to titrate the dosing. Like to recheck labs every about 3 to 6 months and monitor for any side effects, which they're fewer and far between than growth hormone, but they still can include like joint pain, swelling, some glucose intolerance. Again, reassess their quality of life, their sleep, their body composition, their energy levels. I'll generally recommend, I'll tend to lean more to recommending Sermorelin after starting other necessary hormone replacement or fixing metabolic issues, like metabolic syndrome or uncontrolled diabetes. Typical dosing, and again, we can discuss this further, but the typical dosing that you'll see is about 2 to 500, some people say 250, about 2 to 500 micrograms a day. Now, the formula that Southend has, A 200 microgram like nightly dose would be about 6 to 7 units. I like to generally start at about like 250 and titrate up if needed, but 250 would be about, on their formulas, about 8 units. All the way up to the max, like 500 micrograms would be about around 16 units, or 0.16 mLs. Frequency, there's a lot of practitioners that vary on this. I like to recommend them doing it Monday through Friday at bedtime. Some people do it, every day of the week. So it's either 5 or 7 days a week. Like I was discussing earlier, at the 3 milligram per ml dose that Southend has, that yields about 3,000. I use 3,000 units per ml. So the 5 ml vial that we have will generally last about 28 days at the 500 microgram daily dose, which is about 16 units. It will last longer, slightly longer, not much longer, if you lower the dose a little bit. My common patient-reported improvements generally include improved cognitive function, mood, improved mental clarity, focus, reduced brain fog, enhanced mood and emotional stability, sleep across the board. They get more deep, restful sleep, easier sleep onset, fewer nighttime awakenings. Physical function, they report increased muscle mass, strength, improved stamina, recovery, reduced body fat, especially visceral fat, which I check again with the DEXA. I have that VAT program, which has a visceral adipose tissue score. Joint and bone health, decreased joint stiffness and pain, better flexibility and mobility. Their metabolic function improves. They get improved fat metabolism, enhanced insulin sensitivity, which is supported by the clinical data I shared earlier. Stabilized blood sugar levels, and just overall general wellness, like more consistent energy levels, increased vitality, improved libido in some patients. This is an important, they all want to know, when am I going to see results? Okay. So what I'm generally seeing is weeks 2 to 4, you generally see the improved sleep and energy pretty quickly. Months 2 to 3 is when the changes in the body composition and mood occur. And then months 4 plus is where you see the strength, recovery, and then the cognitive effects are more noticeable. So for final note, not everybody responds the same, okay? Just like with any therapy. Results depend on the age, their baseline IGF-1 levels, lifestyle, treatment, adherence, like how adherent are they to giving their injection every night. Effects are gradual and cumulative, so it's really important to counsel the patient that consistency is key. I always tell them that, the first month is kind of just the starting loading dose, and then after that, they'll start to see the benefits improve after month 2 to 3, and then on. So that's basically it in a nutshell. So I look forward to all the questions. And thank y'all for having me. I appreciate it, and feel free to send over any questions. I would love to answer anything y'all have.
Thank you so much for such an engaging presentation, Dr. Villarreal. We did have quite a few questions and wanted to make sure we can get to all of those. So we will go ahead and work on those. I think there were a couple for our clinical pharmacists. Maybe we can start with those first, because those are more just about like who and how, and then we can get into more details. So we'll wait for those to be populated. Oh, for Dr. V. Okay, we'll go with you, Dr. Willie. Do you recommend testing for NAD? How do you determine baseline and what is needed?
Well, it all depends on the patient. Some of the patients don't want to spend, they're already spending a lot of money. Most of it is symptom driven. So like I said earlier, if they're feeling something, they're going to feel the benefits. Could you do testing? Absolutely. I think in the future, the testing is going to get a lot better, a lot cheaper, just like with technology, with so many other things. But right now it's pretty cost prohibitive. So is it absolutely necessary? I would say for Sermorelin, yes, I like to track the IGF-1 levels. That's very easy. That's a simple lab. Any lab has it. the NAD is a little bit more complicated. You know, it's like I said, the testing is not that great for whole blood NAD and NADH. It's very unstable, leading to kind of variable results. But like Genova Diagnostics has a really good metabolomic test where you can test all the precursors. So if the patient really, really wants it, then yeah. But they got to understand that it ranges from $399, about $400 to $500 just to test for that Now you get a bunch of other things in that metabolomic test, but if they're just testing specifically for NAD and NAD precursors, I mean it's a lot. I mean, it'll be more of your high income earners and people with disposable income that are going to be able to do that.
Absolutely. Thank you. Okay, we'll go on to the next. What strengths do we make NAD plus and Sermorelin right now? That's for Asiya. Oh no, I think you're muted.
Sorry.
There you are.
Sorry. So right now for the NAD plus, we make 200 milligrams per ml vials. They're like the 2 ml vials. And for the Sermorelin, it's the 3 milligrams per ml. It's a 6 ml vial. That's what we make right now. That's the only strength we make right now. But they're both injectables.
Yes, and we'll be looking forward to releasing more products and hopefully more strengths in the future. What is the best delivery system? I think that was touched on a little bit during the presentation, but happy for either of you to give your 2 cents.
Well, so I do and have done a lot of IVs. I do them almost daily. I mean, people come in because they're seeing them on social media. They are 100% effective, but you have to monitor the patient. It has to be run in very, very, very slowly. It is effective, but in reality, who's going to do an NAD IV every couple of weeks, once a month from now on? You know what I mean? It's in the ease of the use. Injection, they generally get over the fact, I mean, it's a tiny little, 31 gauge needle. They get over the sub-Q, injections, and they feel that pretty regularly. But as far as, to answer the question, the best delivery system is IV. What is the patient going to comply with the most? It's going to be oral or injection. The injection, like I said, it comes down to bioavailability. The orals have a bioavailability, they say in studies, about 30 to 50%. They do effectively raise levels about 1.5 to 2.5 times in the studies, but again, there's a lot of gut variability. There's a lot of absorption issues. There's a lot of people coming in with GI and gut issues. So if you want to bypass all that, and the injection is the way to go, and it's not too invasive. I mean, it's just a small little sub-Q, or it can be IM a little bit if you do it in the delt. Some people do it delt-wise, and that's fine. It'll absorb the same. But as far as bioavailability, probably injection and IV.
I agree. The ease of use, especially people, it's hard for patients to come in and get IVs and be compliant.
Mm-hmm. Real quick on the NAD, because if y'all open social media, it's everywhere. The jury is still out. Be very careful on these liposomal NAD, where it just says that it's NAD. I'm not saying that they don't work, but historically, if you look at any of the work with Dr. David Sinclair, NAD is a very, very unstable itself molecule orally, and very, very poorly bioavailable for GI absorption. They claim with the liposomal covering that it gets through the gut, but there's more studies on NR and NMN as precursors than there are as NAD itself as a molecule being taken orally. So just be real careful, because there's a couple of them out there that are super popular right now, and they're claiming to deliver NAD itself orally. The jury's still out on that. I'm not so sold on that yet.
Yes, and then I'll also just send a reminder that we have recorded this entire presentation. It will be uploaded to our YouTube pharmacy channel, and we do have quite a few questions to get to, so we'll continue with those, but you can anticipate a recording of this event. And then the next question for how long should we keep them on these supplements? Probably Dr. Willie?
Till the day you die. How long do you want to feel good and how long do you want to be healthy? I mean, you can press pulse it. I mean, Sermorelin, it doesn't, speaking specifically about Sermorelin, like, you know, talking about when you see the benefits, Sermorelin is more of a cumulative over time. So, NAD is a little bit quicker acting. So NAD, if they want, they can go on and off, especially based on cost, right? So they can, and they can even split it up. I have some people that do it every other day or every third day. Okay. Ideally, you would want it daily. But I do see that the longer that somebody uses, say like NAD, you can extend it. Like me personally, I can extend it out every other day or every third day once you build up a good saturation rate. Now, Sermorelin is going to be one of those where, yeah, I mean, as long as you want to maintain a good level, there are some people that do like 6 months on, 6 months off of the Sermorelin, but I wouldn't use it any less really than 3 to 4 months at a time.
Can NAD be given once a week to avoid daily shots, like a larger dose?
You can do it. What I've seen with patients, like I said, is every other or every third day. You can extend it out. They'll still see a benefit because honestly, with the injection, depending on the dose, you feel it. Like you feel it and if you don't increase the dose, you'll feel it. So it's something that they do generally feel. It's a really, really hard feeling to describe, but they feel like almost like this adrenaline rush, you know, within the first few minutes, sometimes seconds. But yeah, I mean, you're just not going to get as much of the benefit as you do it every day or every other day. It's just a dose dependent response.
How do we determine dosages by symptoms, blood work, or BMI?
I would say like for clinicians, they should just kind of individualize this, you know, depending on what your goals are, what the baseline health is of the patient, you know, of course, the age, the biomarkers. It's just highly individualized.
For every medication, hormone, supplement, I am always a big fan of the saying, start low, go slow. Okay. Yep. If I start somebody on NAD and they get this like huge, like if you don't counsel them, tell them what to expect, and I give them this like really intense nice and flush or kind of they don't feel well, they're not likely to do it anymore. So it's best to kind of slowly titrate it up. So yeah, I would say that basically it's very individualized, but I would start low, go slow. I would start at the lower end and titrate up. You can always go up. It's hard to go back down.
What labs are needed for Sermorelin initiation, and how often will you monitor them?
I generally get baseline, like I said, a baseline, the labs that I was talking about, baseline that you should get, you know, your CompMet, your CBC, just check general function, but the main one would be IGF-1. And that would dictate, do I need to lower it? Do I need to raise it? Where are the IGF-1 levels? Because that is a better proxy marker, like I said, than GH. If somebody draws GH, if you go to a doctor and they're drawing your GH during the day, they probably don't know what they're doing. Growth hormone is very, very low to not even existent during the day. So like I said, it peaks about 2 a.m. So IGF-1 is a much better marker. And then labs, I like to do them when I initiate, I like to do labs at 8 weeks, and then after that, every 3 to 6 months. Generally, every 6 months is what I do.
Okay, and then we had another question come through for you, Dr. Willie. I currently offer BHRT, and it seems like a strong addition to enhance patient outcomes. How can I integrate this into what I'm already doing?
So
I know you.
yeah, we talked about that. Yeah, we talked about that yesterday, Haley. So
Yeah.
I also specialize in BHRT and hormone therapy, and so what I do is you want to initially when they come in, you want to fix those things. They're menopausal and hot flashes and having the all the menopausal climactic symptoms. You want to fix that. So what I'll do is generally I will fix the foundation of the house, okay, get them feeling better, and then once they feel better, then I explain it to them in the beginning. It's all in the counseling. The next step would be a Sermorelin. The next step would be because if somebody comes in and they're not experienced with any kind of hormone therapy, with injections, with whatever type of BHRT you're doing, and then all of a sudden you tell them, hey, I need you to do this injection every single day in the morning, and then every single night at bedtime, they're going to be like, I'm out. It's too much too soon. So it's something it works way better as a progression instead of just starting in the beginning and you're going to do this and you're going to do this, you're going to do everything. Because then also they don't know what is helping, what's working. So is it more the testosterone, estrogen, progesterone, testosterone for men? Is it, or is it the NAD, or is it? So it's a next level thing. It's an additional thing that I use that I have to do it. But it's super, super powerful, especially if they're 40, 50 plus.
Does this also cause increased appetite? I guess that's Sermorelin.
Yeah, Sermorelin. It's hit or miss. It's not as bad as some of the other peptides. There are some peptides that will make you want to eat your arm off. Like you will be hungry. Like you will be very, very hungry. I don't generally hear that or see that with Sermorelin. If it does happen, it's going to happen more in the men. But I haven't really seen that as much as some of the other peptides. There was one that was around for a very long time. A lot of clinical studies on it, but it was ibutamoren or MK677. That was an oral growth hormone peptide. That made people extremely, extremely hungry. That's no longer user really available. But not really with Sermorelin. I have not seen that with Sermorelin.
Okay, another question for Asiya: is the NAD frozen when shipped? Does it?
So you mean when the powder comes in, or are you saying when we ship it out?
I believe ship it to the providers or patients is probably how this is being framed.
So no, it's refrigerated. When it's frozen, we do like next day air, and we put the ice bricks in it so that it maintains the temperature. And then we have a temperature indicator in there as well. So that person receives it, they can check the temperature indicator and make sure that it's maintained the temperature.
I think they may be wanting to know if it's lyophilized, like powdered, and then they have to mix it, because some patients want to know, like, do I have to mix it when I get there? If it already comes in a liquid form, then
it does. When we ship out, the one we make it is not lyophilized. It's not a powder. It is already pre-mixed. It's a solution. The beyond use date right now is the 45 days. We are doing stability tests on it to increase the beyond use date.
Important to understand, guys. It doesn't become poison. I get a lot of patients are like, well, what happens if it gets past the best use date? I'm like, nothing really. I mean, for the most part, it's probably still, especially doses, it's still going to work. You just can't guarantee strength. That's what it comes down to. But patients worry is like, oh my God, does it go bad? It's like, no, it's fine.
Is Sermorelin therapy appropriate for patients with hypothyroidism and are also on medication to control it?
Yeah, I mean, so yeah, it's absolutely great for people, but not specifically for hypothyroid, for the use of like fixing hypothyroid. As long as they're looking at thyroid and using either desiccated thyroid if needed, or thyroid supplementation if that's what's needed. I would focus on the hypothyroid and get those levels good. But yeah, it's absolutely appropriate for hypothyroidism. Conjunctive therapy, adjunct therapy, not primary therapy. I wouldn't use it as primary therapy for hypothyroidism. But yeah, to answer that question, yeah, very appropriate for hypothyroidism as long as they're on medication to control it.
Can you speak about Sermorelin and NAD supplementation in the geriatric population, and then patients in their 60s, 70s using Sermorelin for sarcopenia?
The single best group that would benefit from it. I mean, that's what you want. You don't want. I strive to try to build muscle in my elderly group. Like they have to. And here's the sad part is most doctors, providers, they're not even talking about age-related sarcopenia with these patients at all. They're not telling them how to maintain or improve muscle mass. They're not talking to them. They basically tell them, some of them, not even to exercise. And that's ridiculous. I mean, you now, I get if they have an injury or they have a limitation, but you have to move them in some way, shape, or form. There's a lot of compounds coming out that are actually targeting this, or there's pretty amazing supplements that are coming out. But for this age group, 60, 70 years, I mean, that would be prime, because that is the primary, like that's when the majority of growth hormone is completely gone. They have very low IGF-1, very low growth hormone due to age. And then NAD for sure, 50 plus is when that's when we see the most depletion, is 50 plus. So those are prime patients for both of these therapies. Yeah. Without a lot of the, like I was saying, the contraindications that I mentioned earlier.
What dose would you give to that geriatric population?
Start low, go slow. The lower end. So for Sermorelin, it would be in that 200 microgram range nightly, and then for NAD, I mean, you would start like super low, 10 maybe 10 milligrams, okay, and then titrate up as needed.
I had one patient say she thinks NAD plus gives her energy, but only for about an hour after administration of a sublingual dose. She feels cranky or short-tempered after that.
NAD gives her energy, but after administration.
So this is a sublingual administration.
Yeah. I don't know if that's NAD. Is it a precursor? I don't know if it's a precursor or what. Not so sure that the sublingual absorbs as well. NAD itself, like I talked about, man, it's super finicky and unstable. So I'm not sure like a troche or a sublingual would really, it might be in the absorption of it. But again, I would err on the side of like sub-Q versus, I mean, it's a lot more effective. And then at worst case scenario, use NR or NMN. There's a lot of people that the jury's still out on which is better orally, NR or NMN. So there's a lot of people that are taking both, but then that starts to increase. I'm like, just take NAD injection if you're taking both NR and NMN, you know. So, and they're not needle phobic. So.
Have you heard of an association between NAD plus and this particular behavioral side effect as a follow-up question?
No, not cranky, or I mean, I think I would maybe harken back to like, are they already kind of naturally predisposed to be like that? You know, some of the guys come in, you know, like testosterone, they'll come in and they're like, oh, it made me super, you know, it made me like a jerk. And I'm like, you're probably already a jerk before. It's not the testosterone. Now, but as far as like that crankiness and stuff, no, she may be maybe having a little bit more, almost like I don't want to say anxiety. They get this like rush of energy, like they just don't know what to do with it. And so if it's maybe focused on, if maybe they have a lot of emotional stressors already. I mean, there's a lot of things that I like the 5 things that I talk about. Medication and hormones are over here. The basics have to be taken care of, and it's diet, nutrition, hydration, exercise, activity, sleep, emotional, spiritual, mental health. Okay. Then we get over here, because if somebody is in a crisis mode, if they're having a lot of like marital stress, relationship stress, work stress, all these things that are exacerbating it. I mean, it's multivariable, but as NAD itself causing that, I haven't seen that. I haven't seen it specifically causing a mood change.
Does Sermorelin raise IGF-1 or GH above physiologic levels?
I haven't seen that. I haven't seen that at all. IGF-1 can get close, but then you just lower the dose. But I've never seen it get out of hand or too high to where people are like, oh my God, there's really not, it's not going to really give a lot of the GH side effects like the carpal tunnel syndrome and swelling and the glucose, the blood sugar dysregulation. It is just so much safer to use than growth hormone without all the unknowns. It's just a smaller peptide. That's all it is.
Could post-injection erythema, itching, paresthesias, and palms, feet be histamine related, and how can it be minimized? Should patients continue or to stop Sermorelin?
Yeah, so I have seen that. I have seen that in about 10% or less patients. I've seen them. I've top of my head, I can think of maybe 2 to 3 that just simply didn't tolerate it. Okay. There were some that right after injection, they would get a really, really intense flushing and their heart rate would go up. And here's the thing is, I counsel them on this. It doesn't generally happen, but I tell them that if it does, that's normal, but I still want to know about it. So they'll call the office, tell me about it. But I have had just 2 to 3 people that were not able to tolerate it, and it was just like it would make their heart rate go fast. It didn't matter, and I would even tell them to lower the dose. It didn't matter how low of a dose they did; they were just hypersensitive. Now, as far as I haven't seen any paresthesias. Could they be histamine related? Absolutely, but it's generally more due to the vasodilation that happens, and you can get an intense. Now, it does tend to go away if they do get it, and if it's mild. If it's mild, I just tell them to just lower the dose a little bit, push through it, and then it'll eventually go away. Some people, it's just intense no matter what the dosing is or how much they lower it, and in that case, we may just have to reevaluate, and it may not be for them. You have every patient, every doc has those like hypersensitive patients that they just, no matter what you give them, they're just weird, and they're going to have these weird reactions. They generally come in and tell you that. Also, they'll say, hey, I'm really, really, really sensitive. And so just pay attention. But how can it be minimized? I mean, you don't want to have them take any, Benadryl regularly or anything like that. I would just kind of monitor it closely. And like I said, I have had to stop it, but extremely rare, like maybe 3 off the top of my head that I can think of.
And then I guess this is for Sermorelin, like as a follow-up question, what is max weekly dose?
Of Sermorelin really isn't a max weekly dose. The max that I would say nightly dose would be max of 500 micrograms. Do you have any other recommendations pharmacy wise?
Not really. I mean, like I said, it's so individual. If they're able to tolerate it, they'll go up a little bit. If not, but like what you were saying about even the histamine reaction, that's one of the reasons I also always say just start a little bit lower. Even if you think this patient can tolerate it, it's just so much easier to control. You start lower. But as far as max, you're on it, no?
Yeah.
It just depends, yeah.
Yeah.
Okay, well, that is all the questions we have for today. Thank you so much for your participation and involvement. Dr. Villarreal for an excellent presentation. Asiya for standing by, helping with clinical questions. We look forward to pushing this out. It'll be uploaded to our YouTube channel, and the link will be shared after the presentation. We look forward to future education opportunities and hope to connect with you soon. Thank you so much.
Thank you.